What happens when the very people sworn to save lives turn their backs on someone who risked everything to save others? What happens when prejudice blinds medical professionals to the point where they're willing to let a decorated war hero die on their watch? This isn't just another story about medical negligence. This is about Sarah Chen, a woman whose scars told stories that no one bothered to read. A woman whose quiet demeanor masked years of classified operations in the world's most dangerous places. A woman who survived enemy bullets, IED explosions, and torture chambers only to face her greatest battle in a place that was supposed to be safe, an American hospital. The medical staff saw what they wanted to see: another homeless woman, another addict, another burden on their system. They missed the disciplined posture, the tactical awareness, the way she assessed every exit in the room. They ignored the precision of her speech and the calculated calm in her voice. Most crucially, they dismissed wounds that were clearly not self-inflicted, marks that spoke of combat, of sacrifice, of service to a country that had now forgotten her. What they discovered too late would shake the very foundations of the medical center and expose a truth so shocking that it would make national headlines. Because Sarah Chen wasn't just any patient, she was a Navy SEAL, one of the first women to complete the most grueling military training in the world, a ghost operator whose missions were so classified that her own family believed she worked a desk job. This is the story of how prejudice nearly killed a hero, how assumptions can be deadlier than any weapon, and how one woman's fight for her life became a fight for dignity, respect, and justice. This is the story of Sarah Chen, the SEAL they left to die. The automatic doors of St. Mary's Medical Center slid open with a mechanical whisper as Sarah Chen stumbled through the entrance. Her left hand pressed firmly against her right shoulder where dark crimson had soaked through her grey hoodie, creating an irregular stain that grew larger with each passing moment. Her breathing was controlled, measured, the kind of breathing pattern drilled into soldiers during combat training. But her face had taken on the pale, waxy complexion that emergency room staff knew meant serious blood loss. At 34, Sarah carried herself with an unconscious precision that most people never noticed. Even wounded and clearly in distress, she moved with purpose. Her dark hair, pulled back in a practical ponytail, framed a face that revealed nothing of the pain she was experiencing. Years of training had taught her to compartmentalize, to push through agony, and maintain operational focus. But tonight, as she approached the reception desk of what should have been her sanctuary, that training would prove to be both a blessing and a curse. The emergency room was experiencing one of those typical Friday night rushes that veteran medical staff had learned to expect. The waiting area buzzed with the usual mix of genuine emergencies and non-urgent cases that could have waited until Monday. Drunken college students nursing hangovers they mistook for alcohol poisoning sat next to parents clutching feverish children. An elderly man held his chest dramatically, though his vital signs suggested nothing more serious than heartburn from his evening meal. Behind the reception desk, Margaret Torres had been working the night shift for 18 years. She had seen every type of patient imaginable walk through those doors, and she prided herself on being able to assess the severity of cases with a single glance. Tonight, as she looked up from her computer screen to see Sarah approaching, her experienced eye made rapid calculations that would prove to be catastrophically wrong. What Margaret saw was a young woman in clothing that had seen better days. The hoodie was not just blood-stained, but appeared worn and slightly oversized. Sarah's jeans had small tears that Margaret's mind immediately categorized as signs of rough living, rather than the result of diving for cover during a firefight 3 days earlier. Most damning in Margaret's assessment was Sarah's demeanor. Too calm, too controlled, for someone who was supposedly seriously injured. In Margaret's experience, real trauma victims were emotional, frantic, demanding immediate attention. "Can I help you?" Margaret asked, her tone carrying the particular brand of professional skepticism that develops after years of dealing with drug seekers and frequent flyers who abuse emergency services. Sarah approached the desk with steady steps, though anyone with medical training who looked closely would have noticed the subtle signs of compensatory movement. The way she favored her right side, the slight tremor in her left hand that wasn't holding pressure on her wound. Her voice when she spoke was clear and concise. "I need medical attention. I have a penetrating wound to my right shoulder. I've lost approximately 200 milliliters of blood based on the saturation pattern, and I'm experiencing decreased sensation in my fingertips, which suggests possible nerve involvement."
Margaret's eyebrows raised at the clinical precision of Sarah's description.
In her experience, patients who used medical terminology were often either healthcare workers themselves or individuals who had researched their symptoms online, usually to fabricate complaints for various reasons. The calm, almost detached way Sarah described her injury triggered Margaret's skepticism rather than concern. Okay, let me get some basic information, Margaret said, pulling up a new patient form on her computer. Name? Sarah Chen. T-H-E-N. Address? Sarah hesitated for a fraction of a second, a pause so brief that most people would have missed it entirely. The truth was that Sarah's current address was classified information. She had returned from a mission only 4 days ago and was staying in a safe house while being debriefed. Her official address was a post office box that served as a cover for her real identity. I'm currently between addresses, Sarah answered honestly. Margaret's fingers paused over the keyboard. This response, combined with Sarah's appearance and her overly clinical description of her symptoms, painted a picture that Margaret had encountered hundreds of times before. Another homeless individual, probably with substance abuse issues, seeking pain medication or a warm place to stay for the night. Insurance? I have government health benefits. Military. Sarah reached into her back pocket with her left hand, moving slowly to avoid aggravating her shoulder wound. She pulled out a wallet and retrieved what appeared to be a standard military ID card. Margaret glanced at the ID without really examining it. Military IDs were not uncommon in this part of the city given the proximity to several bases. What she failed to notice was that Sarah's ID was different from standard military identification. It had special markings that indicated she held a security clearance level that required congressional approval. What kind of wound are you claiming to have? Margaret asked, the word claiming carrying clear skepticism. Sarah slowly pulled her hand away from her shoulder, revealing the extent of the blood saturation. The fabric of her hoodie was soaked through in an area roughly the size of a dinner plate. When she lifted the edge of the garment, Margaret could see what appeared to be a genuine laceration, though she couldn't assess its depth from her position behind the desk. It looks like you might need a few stitches, Margaret said dismissively. But first I need to ask, have you used any drugs or alcohol in the past 24 hours? The question hung in the air like an accusation. Sarah's expression didn't change, but behind her eyes, something shifted. She recognized the tone, the assumption, the prejudgment that was taking place. In hostile territory, she had learned to identify threats quickly, and right now, she was sensing that the greatest danger might not be her untreated wound, but the biases of the people who were supposed to help her. No drugs. No alcohol, Sarah replied evenly. Margaret made a note in the computer, though her expression suggested she didn't believe Sarah's response. Any allergies to medications? No known allergies. Previous suicide attempts or self-harm? The question was asked routinely, part of the standard intake protocol, but Sarah heard it as another assumption. The medical staff was already constructing a narrative in their minds. Homeless, possibly addicted, potentially mentally unstable.
No,
Sarah answered simply. Margaret finished the basic intake questions and assigned Sarah a triage level that would put her behind several other patients, including the man with heartburn and a teenager who had come in claiming severe abdominal pain but had been texting friends and laughing for the past hour. Take a seat in the waiting area, Margaret instructed. Someone will call you when it's your turn. Sarah nodded and found an empty chair in a corner of the waiting room where she could keep her back to the wall. Another habit from her military training that allowed her to maintain visual contact with all potential threats and exit routes. She resumed pressure on her wound and settled in to wait, unaware that her calm, disciplined response to pain and stress was being interpreted as evidence that her injury wasn't serious. Dr. Amanda Foster was nearing the end of a 12-hour shift that had tested her patience and professional composure. At 29, she was relatively new to emergency medicine, but had already developed the kind of clinical cynicism that helped healthcare workers cope with the constant stream of human suffering and, unfortunately, human deception that flowed through emergency room doors. When she glanced at the patient list on her computer screen and saw Sarah's case summarized as homeless female, minor laceration, possible drug-seeking behavior, her heart didn't exactly sink, but it certainly didn't race with medical urgency either. These cases were part of the job, but they were also the ones that consumed disproportionate amounts of time and resources while offering little in the way of professional satisfaction. Dr. Bell Foster had no way of knowing that the woman sitting calmly in her waiting room had spent the last 6 years of her life in some of the most dangerous places on Earth. She couldn't have known that Sarah had been shot twice before, had performed field surgery on teammates under enemy fire, and had once walked 14 miles through hostile territory with a concussion and a broken rib to reach an extraction point. What Dr. Foster saw when she finally called Sarah's name 2 hours later was simply another Friday night case. A patient who would probably require minimal treatment and maximum patience as she dealt with whatever combination of social, psychological, and substance abuse issues had brought her to the emergency room. Sarah stood when her name was called, moving with the same measured precision she had maintained throughout her wait. The blood loss was beginning to affect her more noticeably now. She felt slightly lightheaded when she stood, and her fingers had developed a concerning numbness that suggested her initial self-assessment about possible nerve involvement had been accurate. "Follow me," Dr. Foster said, leading Sarah down a hallway lined with examination rooms. The room they entered was typical of emergency departments everywhere. Sterile, functional, equipped with the basic tools needed to assess and stabilize patients before they were either discharged or admitted for more extensive treatment. Dr. Foster gestured to the examination table. "Have a seat and let's take a look at what you've got going on," she said, her tone professional but lacking the urgency that would typically accompany a case involving significant blood loss. Sarah carefully removed her hoodie, revealing the full extent of her injury for the first time. The wound was located just below her right shoulder, approximately 3 inches from her armpit. It was clearly a deep laceration, roughly 2 inches in length, with clean edges that suggested it had been caused by a blade rather than blunt force trauma or accident. Foster's expression changed slightly as she saw the actual wound. It was more severe than she had expected based on the triage notes, and the blood loss was clearly significant. But what struck her most was the location and nature of the injury. In her experience, accidental lacerations in this area were extremely rare. The wound's characteristics, its depth, its clean edges, its placement, suggested either an assault or, more likely given the patient population she typically dealt with, self-inflicted injury. "How did this happen?" Dr. Foster asked as she began to examine the wound more closely. Sarah had anticipated this question and had prepared an answer that was truthful but vague. She couldn't explain that the injury had occurred during a classified operation, or that the knife had belonged to an enemy combatant who had managed to get close enough to engage in hand-to-hand combat before Sarah had neutralized the threat. "I was cut by a knife," Sarah said simply. Dr. Foster's suspicions were confirmed. The vague, non-specific answer was exactly what she expected from someone who was either being evasive about the true nature of their injury or who had inflicted the wound themselves and was reluctant to admit it. "Whose knife?" Dr. Foster pressed. "Someone who was trying to hurt me." The answer was completely honest, but in the context of Dr. Foster's assumptions about Sarah's background and circumstances, it sounded like the kind of story that homeless individuals often told to explain injuries that resulted from drug deals gone wrong, disputes over territory or resources, or domestic violence situations that they were reluctant to discuss honestly. Dr. Foster began cleaning the wound, noting its depth and the fact that it would indeed require sutures. As she worked, she also noted several other things about Sarah that reinforced her growing suspicion that this was not a straightforward assault case. Sarah's muscle tone was exceptional, not the kind of fitness that came from casual exercise, but the kind of conditioning that suggested serious, disciplined training. Her hands, despite her claims of being homeless, were clean and well maintained, with calluses in unusual places that Dr. Foster couldn't quite categorize. Most telling, however, was Sarah's response to pain. Foster cleaned and examined the wound, which should have been extremely painful. Sarah remained completely still and silent. Her breathing stayed controlled, her heart rate remained steady, and she showed no involuntary responses to what should have been significant discomfort. "This doesn't hurt?" Dr. Foster asked, probing the deepest part of the laceration. "It hurts," Sarah acknowledged. "I'm managing it." Dr. Foster had seen plenty of patients with high pain tolerance, but Sarah's response was different. It wasn't the detached numbness of someone under the influence of drugs, nor was it the kind of practiced stoicism that chronic pain sufferers sometimes developed. This was something else entirely, a level of pain management that suggested either exceptional mental discipline or psychological dissociation. "I'm going to need to suture this," Dr. Foster said. "It's deeper than I initially thought, but first I want to get some x-rays to make sure there's no foreign material in the wound, and I'm going to need to ask you some more questions about how this happened." Sarah nodded, understanding that she was about to face a more detailed interrogation about an incident she couldn't fully explain without violating national security protocols. What she didn't understand was that Dr. Bridger Foster's clinical suspicions were leading her down a path of assumptions that would color every aspect of Sarah's treatment. As Dr. Forex said, Foster prepared to order the x-rays. She made a note in Sarah's chart that would follow her throughout her time in the hospital. Patient evasive about circumstances of injury. Wound characteristics and patient behavior suggest possible self-inflicted trauma or involvement in high-risk activities. Recommend psychiatric evaluation and social services consultation. Sarah sat quietly on the examination table, unaware that her calm demeanor and inability to fully explain her injury had just triggered a series of assumptions that would put her life in danger. She had survived enemy fire in 3 different countries, had completed missions that other operators considered impossible, and had earned decorations that were too classified for most people to know they existed. But tonight, in a hospital emergency room in her own country, she was about to face a different kind of battle, one where her greatest enemies would be prejudice, assumption, and the deadly combination of medical authority and human bias. The woman who had been trained to survive in any environment was about to discover that sometimes the most dangerous place a warrior can find themselves is in the place where they're supposed to be safe. The radiology department of St. Mary's Medical Center hummed with the familiar sounds of late-night medical activity. Sarah was wheeled down the corridor on a gurney, though she had insisted she could walk. The transportation was protocol. "Doctor," Foster had explained, though Sarah detected something else in the doctor's insistence, a desire to maintain control over a patient who wasn't behaving according to expected patterns. Technician Robert Kim had been working the night shift in radiology for 7 years, long enough to recognize the subtle cues that differentiated between various types of emergency cases. When he received the order for shoulder x-rays on Sarah Chen, the accompanying notes gave him pause. Possible self-inflicted trauma, patient evasive about circumstances, psychiatric evaluation pending. As Sarah was positioned for the x-rays, Robert couldn't help but notice several things that didn't align with the clinical picture described in her chart. Her posture, even while injured, was impeccable. Spine straight, shoulders square, despite the obvious pain from her wound. When she moved, it was with an economy of motion that suggested someone who had trained extensively in body mechanics and efficiency of movement. "I need you to hold very still," Robert instructed as he positioned the x-ray machine. "Understood," Sarah replied, and then did something that caught Robert's attention. She assumed the position and remained absolutely motionless. Not just still in the way that cooperative patients usually managed, but completely frozen like a statue. It was the kind of stillness that military personnel learned during sniper training or special operations. The ability to control even involuntary movements and maintain a position regardless of discomfort. The x-rays revealed what Dr. Foster had expected to find, no foreign objects in the wound, but they also revealed something she hadn't been looking for. Sarah's shoulder and upper chest showed evidence of old injuries that had healed cleanly and professionally. There were faint shadows where bullet fragments had been removed, surgical markers indicating previous operations, and bone density that suggested someone who had maintained exceptional physical conditioning over many years. Dr. Foster studied the images with growing puzzlement. The old injuries were inconsistent with the profile she had constructed of Sarah as a homeless woman, with possible mental health and substance abuse issues. The surgical work was clearly military grade, the kind of trauma treatment that was typically only available to active duty personnel or veterans with service-connected injuries. But rather than reconsidering her initial assessment, Dr. Foster found herself constructing new explanations that fit her existing assumptions. Perhaps Sarah was a veteran who had developed problems after her service. PTSD, addiction, homelessness were unfortunately common among former military personnel. The old injuries might explain her high pain tolerance and unusual composure under stress. When Sarah was returned to the examination room, Dr. Foster was accompanied by Dr. Richard Henley, the supervising physician on duty. Dr. Henley was 47 years old and had been practicing emergency medicine for over 20 years. He had seen every type of case imaginable and prided himself on his ability to quickly assess patients and determine appropriate treatment protocols. "Chen," Dr. Henley began, settling into a chair across from the examination table. "Dr. Vixen, Foster has filled me in on your situation. We're going to need to ask you some detailed questions about how you received this injury." Sarah recognized the shift in tone. This wasn't a medical consultation anymore. It was an interrogation. Her training had taught her to identify these moments, when cooperation could become dangerous, and when the people who were supposed to be helping her had decided she was a threat or a problem to be managed, rather than a patient to be treated. "I've already explained the circumstances," Sarah said carefully. "I was attacked with a knife. I defended myself. I came here for medical treatment." Dr. Henley exchanged a meaningful look with Dr. Reitzel. Foster. Sarah's continued reluctance to provide details about the incident was being interpreted as evasiveness rather than an inability to discuss classified information. "Miss Chen, we're not the police," Dr. Foster interjected. "We're not here to get you in trouble, but we need to understand what happened so we can provide appropriate care. Were you involved in illegal activity?" Are you in danger from whoever did this to you? Do you feel safe returning to wherever you're staying? Each question was reasonable from a medical perspective, but Sarah couldn't answer them honestly without revealing information about her mission, her identity, and current operational status. The safe house where she was staying was classified. The person who had attacked her was dead, eliminated during the completion of her mission. The circumstances of the injury involved national security matters that she was legally prohibited from discussing. I'm not in any immediate danger, Sarah said, which was true. I just need treatment for my injury. Doctor, Henley made a note in her chart. Ms. Chen, your x-rays show evidence of previous trauma, bullet wounds, surgical procedures. Are you a veteran? This question Sarah could answer honestly. Yes. What branch of service?
Navy. When did you serve? I'm currently active duty.
Dr. Henley's eyebrows raised. This was unexpected information that didn't fit with his assessment of Sarah as a homeless woman with possible psychological issues. Active duty military personnel typically had access to military medical facilities and wouldn't present to civilian emergency rooms unless they were off base and facing a genuine emergency. What's your unit?
Dr. Pitch.
Foster asked. Sarah hesitated again. Her unit designation was classified, as was her rank and specialization. Even acknowledging that she was a SEAL would require revealing information that could compromise operational security. That's classified information, Sarah said simply. Doctor. Henley and Dr. Foster exchanged another look. In their experience, patients who claimed military service but refused to provide details were often fabricating their stories or exaggerating their service records. Real military personnel typically carried multiple forms of identification and were generally forthcoming about their service history. Ms. Chen, Dr. Folive, Henley said with a tone that was becoming increasingly skeptical. We're trying to help you, but you're making it very difficult for us to do our job. If you're active duty military, why aren't you at a military medical facility? Why do you appear to be homeless? Why won't you tell us what unit you're assigned to? Sarah felt the situation spiraling beyond her control. Every truthful answer she gave was being interpreted as evasion or deception. Her legitimate inability to discuss classified information was being seen as evidence of psychological problems or dishonesty. I'm on temporary assignment, she said, which was technically accurate. I can't discuss the details of my work. I came to this hospital because it was the closest medical facility to where the incident occurred. Dr. Foster was growing frustrated with what she perceived as Sarah's continued evasiveness. In her experience, patients who couldn't or wouldn't provide straightforward answers about their circumstances were usually hiding something: drug use, criminal activity, self-inflicted injuries, or psychological issues that made their accounts unreliable. Miss Chen, I'm going to be direct with you. Doctor, Foster said. The nature of your wound, your reluctance to explain how it occurred, your claims about military service that you can't verify, and your apparent homelessness all suggest that you may be experiencing some psychological distress. We want to help you, but that might involve more than just treating your physical injury. Sarah understood immediately what was happening. The medical staff had decided she was mentally unstable, and they were beginning to treat her as a psychiatric case rather than a trauma patient. This shift in perception would color every aspect of her care going forward. I'm not experiencing psychological distress, Sarah said firmly. I have a knife wound that requires medical treatment. That's why I'm here. But her calm, controlled response to what should have been an offensive suggestion was itself being interpreted as a sign of psychological dissociation or denial. Normal patients would have become upset or defensive when their mental state was questioned. Sarah's continued composure was seen as evidence that she was indeed suffering from some form of psychological break. Dr. Henley decided to take a different approach. Ms. Chen, I'm going to have Dr. Jetsio Foster suture your wound, but I'm also going to arrange for you to speak with someone from our psychiatric staff and someone from social services. They can help connect you with resources for housing, job placement, and mental health services. Sarah realized that her situation was deteriorating rapidly. Once the hospital decided she was a psychiatric case, her ability to receive appropriate medical care would be compromised. Psychiatric patients were often treated with less urgency. Their physical complaints were frequently attributed to mental health issues, and they were subject to involuntary holds that could keep her in the hospital indefinitely. That won't be necessary, Sarah said. I just need treatment for my wound. Ms. Chen, Dr. Foster said, beginning to prepare the suturing materials. You don't get to decide what's necessary. We have a responsibility to address all of your medical needs, not just the obvious physical injury. As Dr. Chair, Foster began the process of numbing the area around Sarah's wound. Sarah felt a familiar sensation, the recognition that she was in hostile territory, surrounded by potential enemies who had already made decisions about her fate. But unlike every other dangerous situation she had faced in her military career, this time she couldn't fight back, couldn't use her training to neutralize the threat, couldn't call for backup or extract herself from the situation. The local anesthetic took effect, and Dr. Foster began suturing the wound with competent professional efficiency. But Sarah could sense the change in how she was being treated. The medical staff's movements around her had become more guarded, their conversation more careful. They were no longer treating her as a straightforward trauma case. They were managing what they perceived as an unstable individual who might become unpredictable. The sutures look good, Dr. Foster said as she completed the final stitches. The wound should heal cleanly if you keep it clean and dry. But Ms. Jen, before we discharge you, there are some people who need to speak with you. Through the examination room window, Sarah could see two figures approaching. A woman in professional attire, who was clearly from the hospital's social services department, and a man in a white coat, who appeared to be from psychiatry. Behind them, she noticed a security guard taking a position near the door. Sarah's military training kicked into high gear. She assessed the situation with tactical precision. 3 potential threats. 1 exit that was now being monitored, no weapons available, physical condition compromised by injury and blood loss. She was being maneuvered into a position where her freedom of movement would be restricted, and her ability to make decisions about her own care would be removed.
Secadites.
Dr. Foster, Sarah said quietly. I'm requesting immediate discharge. I've received treatment for my injury, and I want to leave now. Dr. Foster paused in her chart documentation. Ms. Chen, it's not that simple. We have concerns about your safety and your ability to care for yourself. We need to address those concerns before we can discharge you. Sarah felt a chill that had nothing to do with her blood loss. The words, concerns about your safety and your ability to care for yourself, were legal terminology that could be used to justify an involuntary psychiatric hold. Once that process was initiated, she could be kept in the hospital against her will for up to 72 hours while undergoing psychiatric evaluation. The social worker knocked on the door and entered without waiting for permission. She was a middle-aged woman with the kind of professionally compassionate expression that Sarah had learned to distrust. Ms. Chen, I'm Linda Morrison from Social Services. I understand you're having some difficult circumstances, and I'd like to talk with you about some resources that might be helpful. Behind her, the psychiatrist entered as well. Dr. James Wright was a thin man with greying hair who carried himself with a particular authority that comes from having the legal power to deprive people of their freedom based on psychiatric diagnoses. Mr. Chen, I'm Dr. Wright from our psychiatric department, he said, settling into another chair. I'd like to ask you a few questions about how you're feeling and what's been happening in your life lately. Sarah looked around the room and realized that she was now surrounded by 4 medical professionals and a security guard, all of whom had already decided that she was mentally unstable and potentially dangerous. Her calm demeanor, which had been a survival asset in every other dangerous situation she had faced, was now being used as evidence against her. I want to speak with my commanding officer, Sarah said clearly. Dr. Wright made a note. Ms. Chen, can you tell me your commanding officer's name and how I can reach them? Sarah knew she couldn't provide that information without violating security protocols. Her commanding officer's identity, like her own mission assignment, was classified. But her inability to answer what seemed like a simple question would be seen as more evidence that she was either delusional about her military service or deliberately evasive about her circumstances. That information is classified, Sarah repeated. Linda Morrison, the social worker, leaned forward with an expression of gentle concern. Miss Chen, I understand that you might be feeling confused or overwhelmed right now. That's completely normal. You've been through a traumatic experience and you're in a strange place with people you don't know. But we're all here to help you, and we need you to help us understand your situation so we can provide the best care possible. The tone was kind, but Sarah recognized the technique. The assumption that her responses were products of confusion rather than legitimate concerns about security and classification. Every answer she gave was being filtered through the assumption that she was mentally unstable, making it impossible for her to communicate effectively with people who had already decided what her problem was. Dr. Wright began what Sarah recognized as a standard psychiatric assessment. Miss Chen, can you tell me what day it is? Friday. What month and year? Sarah answered accurately, demonstrating perfect orientation to time and place. Have you been hearing voices or seeing things that other people can't see? No. Have you had thoughts of hurting yourself or others? No. Are you feeling hopeless or depressed? No. Dr. Wright continued with the assessment questions, and Sarah answered each one clearly and accurately, but she could sense that her responses weren't changing his evaluation. Her calm, controlled answers to questions about hallucinations, suicidal ideation, and mood disturbances were being interpreted as either denial or evidence of emotional flattening associated with psychological trauma. Miss Chen, Doctor, Wright said finally, I'm concerned about your current mental state and your ability to care for yourself safely. Your presentation suggests that you may be experiencing some form of dissociative episode or psychological crisis. I think it'd be best if we kept you here for observation for a few days while we sort out your situation. Sarah felt the trap closing around her. She was about to be committed to psychiatric observation based on the medical staff's misinterpretation of her military training, her inability to discuss classified information, and their prejudiced assumptions about her background and circumstances. Doctor, Sarah said, her voice remaining steady despite the rising danger of her situation, I'm not experiencing a psychological crisis. I'm a Navy SEAL on active duty. I was injured during a classified operation. I came here for medical treatment, which I've received. I'm requesting immediate discharge. The room fell silent. Dr. Wright, Dr. Foster, Dr. Henley, Linda Morrison, and the security guard all stared at Sarah with expressions that ranged from disbelief to concern. Dr. Wright was the first to speak. Miss Chen, women are not allowed to serve as Navy SEALs. Sarah felt something cold settle in her stomach. The psychiatrist's statement was factually incorrect. The SEAL program had been opened to women several years earlier, and Sarah was part of the first small group of women who had successfully completed the training. But Dr. Wright's confident assertion revealed the depth of the assumptions that were being made about her. That policy changed, Sarah said quietly. Women have been allowed in SEAL training since 2016. I completed training in 2019. Dr. Wright made another note in his evaluation. Sarah's continued insistence on what he believed to be an impossible claim was being documented as evidence of delusional thinking.
Ms.
Chen, Dr. Foster interjected. Even if that were true, it doesn't explain why you appear to be homeless, why you won't tell us how to contact your unit, or why you came to a civilian hospital instead of seeking military medical care. Sarah realized that she was facing an impossible situation. Every true statement she made was being disbelieved, every classified detail she couldn't reveal was being interpreted as evasion, and every aspect of her military bearing and training was being seen as evidence of psychological problems. But she also realized something else. As a Navy SEAL, she had been trained to survive in the most hostile environments imaginable. She had learned to endure interrogation, to maintain operational security under pressure, and to find ways to complete her mission even when everything seemed to be working against her. Right now, her mission was simple: get out of this hospital before the medical staff's prejudice and assumptions led to decisions that would put her life in real danger. Because Sarah was beginning to understand that the greatest threat to her survival might not be her untreated wound, but the well-intentioned but catastrophically wrong medical care she was about to receive. The psychiatric holding room at St. Mary's Medical Center was designed to be safe and calming, with soft lighting, padded furniture, and no objects that could be used for self-harm. For Sarah Chen, being transferred to this room represented a fundamental shift from patient to prisoner. Despite her protests and requests for discharge, Dr. Wright had initiated a 72-hour psychiatric hold based on his assessment that she posed a potential danger to herself. The paperwork was already being processed. Dr. Wright's evaluation cited several concerning factors: delusional claims about military service in a role that wasn't available to women, inability to provide verifiable contact information for supposed military superiors, apparent homelessness despite claims of active duty status, and most damaging of all, what he described as inappropriate emotional regulation and dissociative response to trauma. Sarah sat on the edge of the hospital bed, her sutured shoulder throbbing with a pain that was beginning to concern her more than the medical staff's psychological evaluation. The wound site felt warm to the touch, and she was experiencing intermittent sharp pains that suggested possible nerve involvement or early signs of infection. But requesting additional medical attention would only reinforce the staff's belief that she was seeking drugs or exhibiting attention-seeking behavior. The next 12 hours would prove to be crucial in ways that neither Sarah nor the medical staff fully understood. While Dr. Wright and his colleagues believed they were providing appropriate care for a psychologically distressed patient, they were actually setting in motion a series of medical decisions that would nearly cost Sarah her life. The first sign of trouble came at around 3 a.m. 6 hours after Sarah had been placed on psychiatric hold. She was awakened by intense pain radiating from her shoulder down her right arm. The sensation was different from the initial injury pain. Sharper, more electric, accompanied by a burning feeling that suggested inflammatory response. When Sarah pressed the call button for nursing assistance, the response was delayed by nearly 20 minutes. Night shift psychiatric nurse Patricia Woods finally arrived with an air of professional patience that barely concealed her irritation at being called to deal with what she assumed was drug-seeking behavior. "What's the problem?" Patricia asked, reviewing Sarah's chart with the kind of quick assessment that psychiatric nurses develop after years of dealing with patients whose physical complaints are often manifestations of psychological distress. "I'm experiencing increasing pain at the wound site," Sarah explained. "The pain is different from earlier. It's radiating down my arm and there's a burning sensation. I think there might be signs of infection or nerve involvement." Patricia looked at the wound site, which was partially visible beneath Sarah's hospital gown. The bandage appeared clean and properly positioned, with no obvious signs of bleeding or discharge. What Patricia couldn't see was the subtle redness developing around the suture line, or the slight swelling that Sarah could feel but which wasn't yet visible to casual observation. "The doctor sutured your wound properly," Patricia said dismissively. "Some pain is normal after this type of procedure. I can give you some Tylenol, but that's all that's been ordered." Sarah recognized the tone, the same dismissive attitude she had encountered throughout her time in the hospital. Her medical complaints were being filtered through assumptions about her mental state and supposed drug-seeking behavior. "I'm not requesting pain medication," Sarah clarified. "I'm requesting medical evaluation of what I believe may be developing complications." Patricia made a note in Sarah's chart. Patient continues to focus on physical complaints. No obvious signs of complications observed. Given appropriate pain relief. What Patricia failed to document was that Sarah hadn't actually been seeking pain relief at all. She had been reporting symptoms that suggested her condition was deteriorating. This crucial distinction would be lost as the nursing note was passed along to the next shift. By morning, Sarah's condition had worsened noticeably. The pain had intensified to the point where her military-trained pain tolerance was being seriously challenged. More concerning, she was beginning to experience systemic symptoms, slight fever, general malaise, and a fatigue that was different from simple sleep deprivation. Dr. Sarah Williams, the day-shift psychiatric resident, arrived to conduct her morning evaluation with preconceptions already firmly in place. She had reviewed Sarah's chart, including Dr. Wright's initial assessment and Patricia's nursing notes, and had constructed a clinical picture of a patient with probable PTSD, possible substance abuse history, and current delusional thinking related to grandiose military fantasies. "Good morning, Miss Chen," Dr. Ted Williams said, settling into the standard chair position for psychiatric interviews. "How are you feeling today?" Sarah had spent the night carefully considering her response strategy. She needed to communicate her deteriorating physical condition while avoiding reinforcing the psychiatric assumptions that were preventing her from receiving appropriate medical care. "I'm experiencing concerning symptoms related to my wound," Sarah said directly. "Increased pain, possible fever, systemic fatigue. I believe I need medical evaluation for potential complications." Dr. Williams noted Sarah's continued focus on physical symptoms rather than psychological issues. In psychiatric evaluation, this pattern was often seen as a defense mechanism. Patients would focus on concrete physical complaints to avoid addressing underlying psychological trauma. "Ms. Chen, let's talk about how you're feeling emotionally," Dr. Williams redirected.
You've been through what sounds like a traumatic experience.
"It's completely normal to feel confused, anxious, or overwhelmed." "Doctor, I'm not confused or overwhelmed," Sarah replied with the same calm precision that had characterized all her interactions with medical staff. "I'm concerned about the medical management of my injury." Dr. Williams made a note about Sarah's continued denial of psychological symptoms and her inappropriate focus on physical complaints. "Miss Chen, can you tell me more about your military service? I understand you've made some claims about serving in special operations." Sarah felt the conversation moving back into dangerous territory. Every discussion of her military background led to the same pattern: disbelief, assumptions of delusion, and further entrenchment of the psychiatric evaluation that was preventing her from receiving appropriate medical care.
I'm an active-duty Navy SEAL, Sarah stated simply.
"I was injured during a classified operation. I came here for medical treatment." "Doctor!" Williams had reviewed the current policies regarding women in special operations and knew that while the programs had been open to women, the number who had actually completed SEAL training was extremely small. The chances that a homeless woman presenting to their emergency room was actually a Navy SEAL seemed virtually impossible. Ms. Chen, even if women are now allowed in SEAL training, don't you think it's unlikely that a real Navy SEAL would be in your current circumstances? Without identification, without contact with their unit, appearing homeless? The question contained the same logical trap that Sarah had been facing since her arrival. Her legitimate inability to provide classified information was being used as evidence that her claims were false. "Doctor, I understand your skepticism," Sarah said carefully. "But my current circumstances are related to the classified nature of my assignment. I can't provide details that would compromise operational security." Dr. Williams noted what she interpreted as continued delusional thinking with systematic elaboration. Sarah's responses were internally consistent but relied on unfalsifiable claims about classified information that couldn't be verified. Meanwhile, Sarah's physical condition continued to deteriorate. The infection that had begun developing around her wound site was spreading, causing increased inflammation and the beginning of systemic response. Her body temperature was rising slowly but steadily, and her immune system was beginning to mount a response that would soon require immediate medical intervention. But the medical staff's focus on her psychiatric evaluation meant that routine vital signs monitoring had been reduced, and her physical complaints were being attributed to psychological distress rather than investigated as potential medical complications. The next critical moment came during lunch, when Sarah experienced a sudden spike in pain that left her temporarily dizzy and short of breath. The symptoms lasted only a few minutes, but they represented a significant escalation in her condition that would have triggered immediate medical investigation in a normal patient. When Sarah reported these symptoms to the lunch shift nurse Marcus Johnson, she was told that anxiety and panic attacks were common in psychiatric patients, and that the symptoms she described were consistent with psychological rather than medical causes. Ms. Temiwemen continued. "Chen, what you're describing sounds like a panic attack," Marcus explained with professional kindness. "It's very common for people who have experienced trauma."
The shortness of breath, the dizziness, these are classic anxiety symptoms.
I don't know what the matter would be about that parent. This wasn't a panic attack, Sarah replied firmly. I've never experienced panic attacks, and I know the difference between psychological and physical symptoms.
This was related to my wound. Marcus made a note about the patient's continued resistance to psychiatric explanations for her symptoms and her insistence on medical rather than psychological causation. What he failed to note was that Sarah's vital signs at the time of her complaint showed a slightly elevated heart rate and blood pressure that was consistent with physiological stress rather than psychological anxiety. By afternoon, Sarah's condition had deteriorated to the point where her military training was no longer sufficient to mask her symptoms. Her fever had risen to 101.2 degrees Fahrenheit, her wound site was visibly inflamed, and she was experiencing the kind of systemic malaise that indicated a spreading infection. When Dr. Martinez, the afternoon physician, finally examined her wound site properly, his expression changed immediately. The area around the sutures was red, swollen, and warm to the touch. There was evidence of purulent discharge that had soaked through the bandage, and the infection had clearly progressed beyond the initial wound site. "Chen, this wound is infected," Dr. Martinez said, his tone shifting from psychiatric assessment to medical urgency.
How long have you been experiencing these symptoms?
"Since last night," Sarah replied. "I've been trying to report them, but the staff kept attributing them to psychological causes. Dr.
Martinez quickly reviewed Sarah's chart and realized that her repeated reports of increasing pain, fever, and systemic symptoms had been documented but dismissed as psychiatric complaints rather than investigated as potential medical complications. "We need to start you on antibiotics immediately," Dr. Martinez said, already reaching for his prescription pad. "This infection is more serious than it initially appeared." But as Dr. Foskovich acronym, Martinez began ordering appropriate medical treatment. He encountered an unexpected obstacle. Sarah's psychiatric hold meant that all medical decisions had to be approved by the psychiatry department, and Dr. Began Wright was reluctant to authorize aggressive medical treatment for what he still believed was primarily a psychiatric case. "Dr. Martinez, I've reviewed Ms. Chen's case extensively, Dr. Wright explained when consulted about the antibiotic treatment. While she may have developed a minor wound infection, her primary issues are psychiatric. I'm concerned that focusing on physical symptoms will reinforce her pattern of somatization and avoidance of psychological treatment." Dr. Martinez found himself in an unusual position, trying to advocate for appropriate medical care for a patient whose psychiatric status was preventing her from receiving necessary treatment. Doctor, right, this isn't a minor infection, Dr. Martinez insisted. She's showing signs of systemic involvement. Her temperature is elevated, her white blood cell count is elevated, and the wound site shows clear evidence of spreading infection. Dr. Wright reviewed the laboratory results that Dr. Martinez had ordered. Sarah's white blood cell count was indeed elevated, indicating that her immune system was fighting a significant infection. Her blood cultures would take 48 hours to grow, but the preliminary results suggested bacterial infection that could progress to serious complications without appropriate treatment. Very well, Dr. Wright agreed reluctantly. But I want to continue the psychiatric evaluation. This patient's psychological issues need to be addressed regardless of any physical complications. Dr. Martinez began Sarah on a broad-spectrum antibiotic regimen and ordered more frequent monitoring of her vital signs and wound status. For the first time since her arrival at the hospital, Sarah was receiving appropriate medical care for her actual condition rather than treatment based on assumptions about her psychological state. But the delay in proper diagnosis and treatment had allowed the infection to progress further than it should have. What should have been a straightforward wound healing process had become a serious medical condition that would require days of intensive antibiotic therapy and careful monitoring. As Sarah received her first dose of antibiotics, she reflected on the irony of her situation. She had survived combat operations in some of the most dangerous places on Earth, had been trained to deal with life-threatening injuries in hostile environments, and had successfully completed missions that tested the limits of human endurance. But in a modern American hospital, surrounded by trained medical professionals, with access to advanced diagnostic equipment and life-saving medications, she had nearly died because those same professionals couldn't see past their assumptions about who she was supposed to be. The woman who had been dismissed as a homeless psychiatric patient with delusions about military service was actually exactly who she claimed to be, a highly trained special operations soldier whose calm under pressure and professional bearing had been misinterpreted as evidence of mental illness. The infection that was now being treated with antibiotics had been developing for nearly 24 hours, while medical staff attributed her symptoms to psychological causes. The delay could have been fatal, and even with proper treatment, Sarah would be dealing with complications that could have been easily prevented if her initial reports of symptoms had been taken seriously. But perhaps most disturbing of all was the realization that her case was not unique. The same prejudices, assumptions, and systematic biases that had nearly cost her life were likely affecting other patients every day. People whose voices weren't being heard, whose symptoms weren't being believed, and whose lives were being put at risk by medical professionals who thought they already knew the whole story. The transformation in Sarah's treatment began with a phone call that Dr. Martinez hadn't expected to make. As he reviewed her laboratory results and monitored her response to antibiotic therapy, something about her case continued to bother him. The combination of her precise medical terminology, her exceptional pain tolerance, and the old injuries visible on her x-rays didn't align with the psychiatric profile that had been constructed around her. Dr. Martinez had served as a military medic before attending medical school, and he recognized certain patterns in Sarah's behavior and medical history that his colleagues had missed. The way she described her symptoms was consistent with someone who had received advanced medical training. Her stoic response to pain wasn't psychological dissociation. It was the kind of conditioned response that came from military survival training. Most importantly, the old injuries visible on her x-rays told a story that Dr. Martinez could read but that the psychiatric staff had overlooked. The surgical techniques used to repair her previous gunshot wounds were sophisticated and recent, consistent with current military medical practices rather than older civilian trauma procedures. Miss Chen, Dr. Martinez said during his evening rounds, "I've been reviewing your medical history, and I have some questions that aren't related to your psychiatric evaluation." Sarah looked up from the hospital bed where she had been lying with her eyes closed. Though Dr. Martinez suspected she had been monitoring his approach long before he entered the room, another habit that suggested military rather than civilian background. "What questions?" Sarah asked, her voice still carrying the controlled, professional tone that had characterized all her interactions with hospital staff. "Your previous injuries, the gunshot wounds that show up on your x-rays. When did those occur, and where were you treated?" Sarah hesitated, not because she was being evasive, but because she was calculating what information she could provide without violating security protocols. "The most recent was approximately 14 months ago. I was treated at a military medical facility overseas." Dr. Martinez noted the precision of her response. Not about a year ago, but approximately 14 months ago. It was the kind of specific time frame that someone would remember clearly, especially if it was connected to a significant military operation. What was your role when you were injured? I was conducting operations as part of a special operations team. Dr. Pstoy. Martinez felt a shift in his understanding of Sarah's case. Her previous claims about being a Navy SEAL, which had been dismissed as delusional by the psychiatric staff, were beginning to seem less impossible and more simply unbelievable to people who hadn't considered the possibility that they might be true. Ms. Chen, I'm going to ask you something, and I want you to understand that I'm asking as a physician who's trying to provide you with appropriate care. If you are actually active duty military, particularly special operations, there should be ways to verify that information that don't compromise whatever classification issues you're dealing with. Sarah studied Dr. Rusk. Martinez carefully. Unlike the other medical staff she had encountered, he was approaching her claims with curiosity rather than skepticism, and he seemed to understand that classification issues were real constraints rather than convenient excuses. What do you suggest? Sarah asked. Do you have any way to contact someone who can verify your status without revealing classified information? A base command number, a medical liaison, anyone who can confirm that you're who you say you are? Sarah considered the question. There were protocols for situations like this. Emergencies where special operations personnel needed to verify their identity without compromising operational security. She could provide a contact number for the Navy Special Warfare Command Administrative Office, which could confirm her active duty status without revealing details about her current assignment.
Yes, Sarah said finally.
I can give you a number to call. Doctor. Martinez took down the information and left Sarah's room with a growing sense that his colleagues had made a serious error in judgment. If Sarah was actually a Navy SEAL, the implications went far beyond simple misdiagnosis. They had potentially compromised the medical care of an active duty special operations soldier and subjected her to psychiatric treatment based on fundamental misunderstanding of her background and circumstances. The phone call to the Navy Special Warfare Command took place the next morning. Dr. Martinez spoke with Lieutenant Commander Patricia Hayes, who served as a liaison between special operations units and civilian medical facilities. The conversation was brief but illuminating. Doctor, I can confirm that Petty Officer First Class Sarah Chen is active duty Navy and assigned to Naval Special Warfare, Commander Hayes said after verifying Dr. Martinez's credentials and the circumstances of his call. However, I cannot discuss the details of her current assignment or her medical history without proper authorization. Doctor. Martinez felt a cold knot forming in his stomach. Commander, can you tell me anything about her training or qualifications? Petty Officer Chen completed basic underwater demolition/SEAL training in 2019 and has been deployed multiple times in support of classified operations. Doctor, may I ask why she's receiving care at a civilian facility rather than military medical? Dr. Martinez explained the circumstances of Sarah's arrival at their emergency room and her subsequent psychiatric evaluation. The silence on the other end of the line lasted long enough that he wondered if the connection had been dropped. Doctor, Commander Hayes said finally, her voice carrying a tone that Dr. Martinez recognized as carefully controlled anger. You're telling me that a Navy SEAL was placed on psychiatric hold because your staff didn't believe she was qualified for her job? The implications of the situation were beginning to sink in. Sarah hadn't been treated as a psychiatric patient because she was mentally unstable. She had been treated as a psychiatric patient because the medical staff couldn't accept that a woman could be a Navy SEAL and had interpreted her legitimate inability to discuss classified information as evidence of delusion. Commander, what do you recommend we do at this point? Doctor, I'm going to send someone to verify Petty Officer Chen's condition and ensure she receives appropriate care. In the meantime, I strongly suggest that you review your psychiatric evaluation and consider whether it was based on medical evidence or on assumptions about what women can and cannot do in the military. After hanging up the phone, Dr. Martinez immediately went to find Dr. Bryan Wright to discuss the situation. The conversation that followed would later be described by both doctors as one of the most uncomfortable professional discussions of their careers. Dr. Wright, I've just confirmed Sarah Chen's military status with Navy Special Warfare Command. She is actually a Navy SEAL, and she is actually on active duty. Doctor. Wright's first response was disbelief. That's impossible. Even if women are theoretically allowed in SEAL training, the chances that one would end up here, under these circumstances, Dr. Wright, I spoke directly with her command. She is who she says she is. The silence and Dr. People. Wright's office stretched uncomfortably as the psychiatrist processed the implications of this information. If Sarah was actually a Navy SEAL, then every assumption that had driven his psychiatric evaluation was wrong. Her calm under pressure wasn't psychological dissociation, it was professional training. Her inability to discuss her assignment wasn't evasiveness. It was adherence to security protocols. Her unusual physical conditioning and pain tolerance weren't evidence of psychological issues. They were the result of being one of the most elite soldiers in the American military. Dr. Martinez, if this is accurate, then we've made a serious error in judgment. Dr. Wright, this is more than an error in judgment. We've subjected an active-duty special operations soldier to psychiatric treatment based on our inability to believe that women can serve in combat roles. We've delayed medical treatment for a serious infection because we attributed her symptoms to psychological causes. And we've done all of this while she was unable to defend herself without violating security protocols that she's legally bound to follow. Dr. Duck's secret protocol. Wright reviewed Sarah's chart with new eyes, looking for evidence that should have suggested they were dealing with a genuine military professional rather than someone experiencing psychological crisis. The signs had been there. Her precise use of medical terminology, her exceptional physical conditioning, her measured responses to stress, but they had been interpreted through the lens of existing assumptions rather than evaluated objectively. What do we need to do, Doctor? Wright asked. First, we need to discontinue the psychiatric hold immediately. Second, we need to focus on providing appropriate medical care for her infection. Third, we need to review our intake and evaluation procedures to understand how this happened and prevent it from happening again. The next few hours involved a series of uncomfortable conversations as word spread through the hospital that the homeless woman with psychiatric issues was actually a Navy SEAL who had been receiving inappropriate care for the past 2 days. The nursing staff who had dismissed her symptoms as attention-seeking behavior learned that they had been ignoring legitimate medical complaints from someone whose training included advanced field medicine. The social worker, who had tried to arrange housing services, discovered that she had been offering help to someone who was currently living in a classified safe house as part of an ongoing military operation. Most significantly, the emergency room staff realized that their initial assessment had been so colored by prejudice and assumption that they had failed to recognize a legitimate medical emergency when it presented itself. When Dr. Martinez returned to Sarah's room to explain the changes in her treatment status, he found her exactly as he had left her, sitting upright in bed, alert and aware of everything happening around her, monitoring the corridor through her door window with the kind of situational awareness that civilian medical staff had interpreted as paranoid behavior.
Ms.
Chen? Petty Officer Chen. Dr. Martinez corrected himself. I've spoken with your command. We've confirmed your military status and we're discontinuing the psychiatric hold immediately. Sarah nodded without visible emotion, though Dr. Baleone. Martinez detected a subtle relaxation in her posture that suggested significant relief. Thank you. Petty Officer Chen, I need to apologize on behalf of our entire medical team. We made assumptions about your background and circumstances that led to inappropriate treatment. Your symptoms were real, your medical complaints were legitimate, and your inability to discuss your assignment was due to security protocols that we should have recognized and respected. Sarah looked at Dr. Martinez steadily. Doctor, what's important now is ensuring that this doesn't happen to other patients. The assumptions that were made about me, about my credibility, about my mental state, about my capabilities, those same assumptions are probably affecting other people who don't have military commands that can verify their status. Dr. Martinez recognized the profound truth in Sarah's observation. Her case had revealed systematic biases in their evaluation and treatment procedures that likely affected many other patients whose backgrounds didn't fit expected patterns or whose circumstances seemed improbable to medical staff. You're right, Dr. Martinez acknowledged. This incident has revealed problems in our approach to patient care that extend far beyond your individual case. As news of Sarah's true identity spread through the hospital, a different kind of transformation began to take place. Staff members who had dismissed her as a psychiatric case began to see her differently, not just because she was a Navy SEAL, but because they realized how completely they had misjudged someone, based on superficial appearances and preconceived notions. The woman they had seen as homeless and delusional was revealed to be someone who had risked her life repeatedly in service to her country. The patient they had treated with skepticism and condescension was actually someone whose training and experience far exceeded their own in dealing with trauma and crisis situations. But perhaps most importantly, Sarah's case forced the entire medical team to confront the uncomfortable reality that their professional judgment had been compromised by biases they hadn't recognized. Assumptions about gender, about homelessness, about mental illness, and about who deserved to be believed and treated with respect. The Navy SEAL they had almost let die due to their prejudice was about to become the catalyst for changes in hospital policy and procedures that would protect future patients from the same dangerous assumptions that had nearly cost Sarah her life. 3 days after her true identity was confirmed, Sarah Chen sat in a private hospital room that bore little resemblance to the psychiatric holding area where she had spent her first 48 hours at St. Mary's Medical Center. Her infection was responding well to antibiotic treatment, her wound was healing properly, and her physical condition had stabilized. But the impact of her experience was only beginning to be understood by the hospital administration and medical staff. Commander Hayes had arrived from Naval Special Warfare Command the previous day, not just to check on Sarah's condition, but to conduct what she described as an informal investigation into the circumstances that had led to a Navy SEAL being subjected to inappropriate psychiatric treatment. The meeting in the hospital administrator's office had been described by those present as tense and professionally uncomfortable. Dr. Mitchell, Commander Hayes had said to the hospital's chief medical officer, "I want to understand how your staff concluded that a decorated combat veteran was experiencing psychological delusion when she accurately described her military service." Dr. Richard Mitchell, who had been the hospital's chief medical officer for 12 years, found himself in the unprecedented position of explaining how his emergency room staff had mishandled the care of a special operations soldier. The incident represented not just a medical error, but a potential public relations disaster that could affect the hospital's reputation and its relationship with military patients. "Commander, our staff followed standard psychiatric evaluation protocols," Dr. Mitchell had explained. "But it's clear that those protocols didn't account for the unique circumstances that special operations personnel might face when seeking civilian medical care." Commander Hayes had been unimpressed with this explanation. Dr. Rhett. "Mitchell, your staff didn't follow medical protocols. They made assumptions based on prejudice. They saw a woman claiming to be a Navy SEAL and decided it was impossible rather than considering that it might be true. They saw someone who couldn't provide detailed information about her work and assumed she was being deceptive rather than recognizing that classification requirements might prevent her from answering certain questions." The meeting had resulted in several immediate changes to hospital policy, but it had also initiated a broader review process that would examine how St. Mary's Medical Center approached patient evaluation and treatment across all departments. Sarah's case had become a learning opportunity that extended far beyond the specific circumstances of her visit. Hospital staff were being required to attend training sessions on implicit bias in medical settings, and new protocols were being developed to prevent patient background assumptions from interfering with appropriate medical care. Dr. Wright, the psychiatrist who had initiated Sarah's psychiatric hold, had requested a meeting with her to discuss the case and what he had learned from the experience. The conversation took place in Sarah's room on her final day at the hospital, with Commander Hayes present at Sarah's request. "Petty Officer Chen," Dr. Wright began, "I want to personally apologize for the assumptions I made during your evaluation. I failed to consider that your responses to my questions might be truthful rather than evasive, and I allowed my preconceptions about women in military service to influence my medical judgment." Sarah listened without interrupting, her expression neutral but attentive. When Dr. Wright finished, she took a moment before responding. "Dr. Wright, I appreciate your apology, but what concerns me is that the same assumptions that affected my care are probably affecting other patients who don't have military commands to verify their stories. How many people have been subjected to inappropriate psychiatric treatment because their backgrounds or circumstances didn't fit expected patterns?" Dr. Wright acknowledged the broader implications of Sarah's observation. "You're absolutely right. Your case has forced us to examine our evaluation procedures and recognize biases that we didn't know we had. We're implementing changes to prevent this from happening again." Commander Hayes interjected with a question that had been bothering her since reviewing the case details. "Dr. Wright, even if you had doubts about Petty Officer Chen's military service, why weren't her physical symptoms taken seriously? She reported increasing pain, fever, and signs of infection for nearly 24 hours before receiving appropriate medical attention." Dr. Wright's discomfort was evident as he answered, "We attributed her physical complaints to psychological causes because her presentation didn't match what we expected from someone experiencing serious medical complications. Her calm demeanor made us think she wasn't in significant distress." "Doctor," Sarah said quietly, "my calm demeanor wasn't evidence that I wasn't experiencing distress. It was evidence that I had been trained to function effectively under adverse conditions." The same training that allows special operations personnel to complete missions while wounded also allows us to report symptoms clearly and accurately, even when we're in pain. The conversation revealed one of the most troubling aspects of Sarah's case, her military training, which represented years of conditioning to maintain operational effectiveness under extreme stress, had actually worked against her in a civilian medical setting. The very qualities that made her an effective special operations soldier had been interpreted as signs of psychological problems. Dr. Martinez, who had been instrumental in discovering the truth about Sarah's identity, used her case as the foundation for a research project examining how cultural and gender biases affected medical decision-making in emergency settings. His preliminary findings suggested that Sarah's experience was part of a much larger pattern of disparate treatment that affected women, minorities, and individuals whose backgrounds didn't fit medical staff expectations. The changes implemented at St. TJ Mary's Medical Center, as a result of Sarah's case, included new intake procedures that separated background verification from medical assessment, mandatory training on implicit bias for all medical staff, and protocols for handling patients whose personal circumstances might involve legitimate confidentiality concerns. Most significantly, the hospital established what became known as the Chen Protocol, a set of guidelines that required medical staff to evaluate patient symptoms objectively, regardless of assumptions about the patient's background, credibility, or circumstances. The protocol emphasized that unusual or improbable patient histories should prompt additional investigation rather than skeptical dismissal. As Sarah prepared for discharge, she reflected on the broader implications of her experience. Her case had revealed systematic problems in medical care that extended far beyond her individual treatment. The biases that had affected her care were likely affecting countless other patients who didn't have the resources or authority to challenge medical staff assumptions. The infection that had merely become life-threatening due to delayed treatment had healed completely, leaving only a small scar to mark the incident. But the impact of her experience would continue long after her physical recovery was complete. Local media had learned about the case, though military privacy regulations prevented them from reporting many of the specific details. The story that emerged, "Hospital Mistakes Navy SEAL for Psychiatric Patient," became a catalyst for broader discussions about bias in medical settings and the importance of taking all patients' concerns seriously, regardless of their background or circumstances. Sarah's commanding officer, Captain Jennifer Walsh, visited her on the day of her discharge to discuss both her medical condition and the circumstances that had led to her seeking civilian medical care. The conversation took place in private, addressing both operational security concerns and the lessons learned from the incident. "Chen, how are you feeling physically?" Captain Walsh asked. "Fully recovered, ma'am. The infection responded well to antibiotic treatment once it was properly diagnosed and treated. And the delay in receiving appropriate care, ma'am, the medical staff's assumptions about my background led to inappropriate evaluation and treatment. The situation was resolved once my identity was verified, but it revealed systematic problems in how civilian medical facilities approach patient assessment." Captain Walsh nodded, having already received detailed reports about the incident from Commander Hayes. "Chen, this situation has implications beyond your individual case. We're reviewing protocols for how special operations personnel should handle medical emergencies when military facilities aren't available." The conversation touched on the unique challenges that female special operations personnel faced when operating in environments where their qualifications and credibility might be questioned based on gender assumptions rather than objective evaluation of their capabilities. As Sarah gathered her personal belongings and prepared to leave the hospital, she was approached by Dr. Foster, the emergency room physician who had initially treated her wound. Dr. Foster had been deeply affected by the realization that her assumptions about Sarah's background had contributed to inappropriate care. "Petty Officer Chen, I wanted to speak with you before you leave," Dr. Foster said. "I've been thinking a lot about our initial interaction and the assumptions I made about your case." Sarah looked at the young doctor with the same steady gaze she had maintained throughout her hospital stay. "What are your thoughts?"
I realized that I saw what I expected to see rather than what was actually in front of me.
"Your calm demeanor, your inability to provide certain information, your appearance. I interpreted all of those things through my preconceptions about what homeless people and psychiatric patients look like and how they behave." "Dr. Foster, the most important question isn't what assumptions were made about me, but what assumptions are being made about other patients. How many people receive inadequate care because medical staff have already decided what their problem is before conducting a thorough evaluation?" Dr. Ian Foster acknowledged the broader implications. "You're right. Your case has made me reconsider how I approach patient assessment. I'm working with Dr. Faust Martinez on research into how unconscious bias affects medical decision-making. The research project that emerged from Sarah's case would eventually be published in medical journals and presented at conferences, contributing to a growing body of evidence about the impact of bias on healthcare outcomes. The study found that patients whose backgrounds, appearances, or circumstances didn't fit medical staff expectations were significantly more likely to receive delayed or inappropriate care. 6 months later, St. Mary's Medical Center was recognized as a leader in bias reduction training for medical professionals. The Chen protocol had been adopted by other hospitals, and Sarah's case was being used in medical schools as an example of how assumptions could interfere with objective clinical assessment. Sarah herself had returned to active duty, but the experience had changed her perspective on the intersection between military service and civilian society. She began speaking at medical conferences about her experience, always emphasizing that the lessons learned from her case were about more than just female military personnel. They were about the importance of treating all patients with dignity, respect, and objectivity. The woman who had almost died because medical professionals couldn't see past their prejudices became an advocate for systematic changes in healthcare that would protect other patients from the same dangerous assumptions. Her calm voice in hospital auditoriums carried the same authoritative precision that had characterized her military service, but now it was being used to save lives in a different way, by challenging medical professionals to examine their own biases and commit to providing better care for all patients. The Navy SEAL, who had been dismissed as delusional, had become a catalyst for change that extended far beyond the walls of any single hospital. Her experience demonstrated that the most dangerous enemies of good medical care weren't always obvious. Sometimes, they were the unconscious assumptions and systematic biases that lived quietly in the minds of well-intentioned healthcare providers. Sarah's story ended not with her recovery, but with her transformation from patient to advocate, ensuring that the lessons learned from her near-fatal encounter with medical prejudice would help protect countless other patients who deserve to be heard, believed, and treated with the same respect that should be afforded to every person seeking medical care. The scars from her mission-related injury had healed completely, but the impact of her fight against medical bias would continue to save lives for years to come. Sometimes the most important battles are fought not with weapons, but with words, courage, and the determination to ensure that no one else has to endure the same injustice that nearly cost a hero her life.